Hello. Thank you very much for the opportunity today to share with you a presentation that showcases my informatics project, the implementation of the PHQ-9 electronic form in my avatar. My name is Elizabeth Lafortune, and it's my pleasure to speak with you. In this presentation, I will provide an outline for a psychiatric hospital's implementation of the PHQ-9 form in my avatar to address the inefficiencies in monitoring and improving patient care related to depression screening. The development of a PHQ-9 electronic form will enhance efficiency in collecting, compiling, and reporting clinical data. The system aims to fill an existing gap, providing healthcare professionals with a robust tool to streamline depressive screenings. Ultimately, this project seeks to contribute to improved patient care by offering a more effective means of monitoring and analyzing clinical information. This slide introduces the topics that will be covered in this presentation. This presentation applies the principles of the system development lifecycle. The 6 principles are planning, analysis, design, implementation, testing, and maintenance. As a part of the planning process, the project statement will be identified. The justification and evidence of the project will be communicated. Also, the scope, project plan, communication plan, and general strategies will be covered. Secondly, the analysis phase will include a discussion of the baseline and project-specific data. We will also look at the performance measures. Next, in the design phase, we will have a conversation about the advantages, limitations, and stakeholder needs. The implementation process includes visuals on PHQ-9 form functions and outcomes. The testing phase outlines the proposed testing scenario and plan and provides evidence that it supports the proposed informatics project. We will include how the test results will be documented and how issues will be mitigated. Finally, the maintenance phase outlines what comes after implementation for the life of the PHQ-9 form, including upgrades and enhancements. As part of the planning phase of the SDLC, the purpose of this implementation is to address the inefficiencies in monitoring and improving patient care related to depression screenings within the project site. The project site lacks a standardized and efficient method for assessing and monitoring depression severity, which hinders timely diagnosis, treatment planning, and outcome tracking. The absence of a PHQ-9 tool integrated in my avatar creates operational inefficiencies, such as reliance on paper forms and increased administrative burden. This gap also limits clinicians' ability to monitor system progression over time and adjust treatments effectively. Implementing an electric PHQ-9 form within my avatar addresses these challenges by enabling real-time data collection, secure storage, and seamless integration into patient records. This solution improves clinical workflows, enhances data accuracy, supports compliance with HIPAA regulation, and facilitates better patient outcomes through consistent depression screening and monitoring. Also a part of the planning phase of the SDLC involves justification and evidence for the project. An electronic PHQ-9 improves patient care, which is an objective of the project site. Early detection and monitoring of depression systems allow for timely interventions and personalized treatment plans. Digitizing the PHQ-9 increases operational efficiency by eliminating manual data and reducing administrative workload and errors. Integrating with EHRs streamlines workflows, automates alerts for follow-up care, and enhances accountability in depression screening. An electronic PHQ-9 is a HIPAA compliant and protects patient privacy while enabling secure sharing of health data among care teams. These benefits align with the project site's goals of delivering high-quality care while maintaining compliance and improved patient outcomes. As part of the planning phase of the SDLC, the scope of this project is as follows. This project will integrate the PHQ-9 form into my avatar for the project site, including staff training and workflow design to incorporate depression screening. The scoring and interpretation will be automatic. It will integrate with patient dashboards for tracking symptom trends. There will be no development of new hardware as the focus is limited to software integration and workflow optimization. The PHQ may not capture all psychiatric conditions effectively and may not be applicable to patients who do not show improvement or experience worsening symptoms during treatment. The project must adhere to HIPAA and state-specific regulations for data security and patient privacy. Funding must align with the hospital's allocation for technology. Integration must ensure compatibility with my avatar and avoid disruption to clinical workflow. The timeline for this project is 14 weeks. Phase 1, which is 3 weeks, will involve planning and stakeholder engagement. Phase 2, 8 weeks, will include development, testing, and customization of PH9 integration. Phase 3, 3 weeks, will include training staff, pilot testing, and deployment. The cost of the integration is as follows. The software customization is $8,000, staff training $3,000, and maintenance and support $1,000 annually. Resources include IT professionals for my avatar integration, clinical staff training specialist, and a project manager to oversee the implementation. Manual processes such as paper-based administration are out of scope for this project. We will not be looking at other mental health screenings beyond PHQ-9. Developing or reversing clinical guidelines unrelated to PHQ-9 results is also out of scope. We will not be implementing patient communication tools like MyChart messaging unless directly linked to PHQ-9 follow-ups. Finally, we will not be overhauling unrelated My Avatar functionalities or addressing non-specific IT issues. Further developing the plan, the PHQ-9 will be embedded within My Avatar to ensure seamless data collection and scoring during patient visits. Automating the process reduces administrative burden, ensures consistent use, and integrates results into patient records for better tracking and care coordination. Comprehensive training will be developed and delivered for clinical and administrative staff on administering, scoring, and interpreting the PHQ-9. Proper training ensures accurate implementation, increases staff confidence, and enhances patient care quality. We will configure my avatar to flag high-risk scores and notify relevant staff immediately. This enables rapid response to critical cases, improving patient safety and outcomes. We will implement tools to monitor trends in PHQ-9 scores over time, enabling evaluation of treatment. Tracking outcomes support evidence-based care and helps meet regulatory standards. Completing the scope. The completion criteria is as follows. PHQ-9 is fully accessible as a flowsheet within my avatar. At least 90% of relevant staff complete training on PHQ-9 usage and demonstrate proficiency. A minimum of 80% of patients are screened using the PHQ-9 during the implementation period. Surveys indicate that at least 80% of staff find the tool beneficial for identifying depression and improving patient care. Finally, regular audits confirm accurate documentation of PHQ-9 results in patient charts with automated reporting functionality enabled in my avatar. Implementing the PHQ-9 tool in my avatar requires a structured communication plan to ensure stakeholder alignment, minimize resistance, and support seamless integration. The stakeholders and their roles are as follows. Clinical staff. Clinical staff role is to administer the PHQ-9 screenings, document results in my avatar, and escalate positive screens. The information needed for clinical staff includes training on PHQ-9 administration, my avatar workflows, and escalation protocols. Next, an IT team is needed. Their role is to integrate PHQ-9 into my avatar, troubleshoot technical difficulties, and ensure data security. The information they need are technical specifications, testing timelines, and user feedback. Also, we need administrative leadership. Their role is to allocate resources, monitor compliance, and approve policy changes. The information they need are progress reports, budget updates, and compliance metrics. We, of course, need patients as well to participate in screenings and provide feedback. They need to understand the purpose of the PHQ-9, confidentiality assurances, and follow-up steps. Social workers are needed to conduct evaluations for positive screens and coordinate care. The information they need are screening results, patient history, and referral pathways. You can review the table on this slide, which communicates an overview on communication tools and channels. Key communication events include the pre-implementation phase, which includes a kickoff meeting to announce project goals, timelines, and roles, as well as an EMR demo session to showcase the PHQ integration for clinical and IT teams in my avatar. The second event is the implementation phase. This involves weekly check-ins to address technical challenges and share screening compliance rates. It also includes incentive announcements to recognize high-performing staff. Third, there's a post-implementation phase, which includes reviewing webinars to analyze outcomes, share patient feedback, and refine workflows. The level of responsibility includes for the project lead, they oversee the timeline, resolve conflict, and report to leadership. Clinical supervisors monitor daily screenings, provide coaching, and escalate issues. IT support ensure 24/7 technical availability during rollout. Some barrier mitigation strategies are to address staff resistance through incentives like recognition emails and iterative training. Workflow disruptions can be mitigated by using phase rollouts and real-time feedback to adjust processes. By aligning stakeholders through targeted communication and leveraging tools like secure messaging and training, psychiatric hospitals can ensure effective PHQ-9 implementation while maintaining staff engagement and patient care quality. Implementing an electronic PHQ-9 at the project site requires strategies that address both technical integration and long-term sustainability. One strategy is stakeholder-driven co-design. A multidisciplinary implementation team will be formed including clinicians, IT staff, administrators, and patients to align technical capabilities with clinical workflows. We will use Agile to refine the PHQ-9 interface. We will embed feedback mechanisms to identify any workflow issues. Another strategy we will use is workflow integrated implementation. We will map PHQ-9 workflows using automation to reduce manual scoring. We will also embed the forms directly into templates which auto-trigger alerts for low scores. Some strategies for staying on budget include defining the scope clearly. We will start by thoroughly defining the project scope to avoid scope creep, which is a major cause of budget overruns. We will also do accurate cost estimation. We will break down the project into smaller tasks and eliminate costs for each using historical data, industry benchmarks, and expert input. We will also resource plan, which means we will identify and allocate resources, including people, equipment, software, accurately to prevent overspending and ensure efficiency. We will include contingency reserves. We'll set aside a contingency fund, typically 5 to 20% of the total budget, to cover unexpected expenses or risks. We will use continuous monitoring to track actual expenses versus the budget in real time, using project management software to spot issues early and make timely adjustments. We will use change control to implement a formal process for approving any changes in scope or budget to prevent unplanned costs. We will use efficient communication to maintain open communication among team members and stakeholders to quickly resolve issues and keep everyone aligned. We will use regular reviews and reforecasting. We will review financial progress frequently and update forecasts as the project evolves to stay aligned with current realities. By following these structured steps, clear scope, accurate estimation, resource planning, contingency, monitoring, change control, communication, and regular reviews, IT projects are more likely to stay on budget. As we move into the analysis phase, we will discuss baseline and project-specific data. The required baseline data includes current depression screening practices, including existing tools or methods for depression screening and the frequency and consistency of depression assessments across departments. Baseline data includes My Avatar functionalities, including support for integrating new tools like the PHQ-9 and the availability of flow sheets for recording PHQ-9 results. Project-specific data includes the targeted population and specific outcomes to measure, symptom reduction, and treatment adherence. Project-specific data also includes training needs for staff knowledge of the PHQ-9 tool and its use, as well as training materials and sessions required for effective implementation. Clinical experts, technical experts, and educational facilitators are needed to gather data. Clinical experts familiar with depression screening and treatment protocols, including psychiatrists, psychologists, and nurses, are needed to interpret PHQ-9 results and help integrate them into workflows. My Avatar specialists are needed to integrate the PHQ-9 into My Avatar and ensure seamless documentation. Data analysts must manage data collection, privacy, and analysis. Nurse educators must train staff in administering the PHQ-9 and integrating it into workflows. Administrative support and stakeholder engagement are also needed. The steps needed to gather data include defining the objectives and score, including clarifying why the PHQ-9 implementation is needed, and identifying the departments, patient populations, and staff involved in the project. The next step is to assemble a multidisciplinary team, including clinical staff, IT specialists, and project managers. Furthermore, stakeholder interviews should be conducted to gather qualitative insights. An audit of existing projects must take place, as well as collecting patient demographic data. IT staff must assess current functionalities with My Avatar and opportunities for automation. Finally, an analysis of training gaps needs to be addressed during implementation. To wrap up the analysis phase, let's discuss performance measures. Implementing an electronic PHQ-9 in A psychiatric hospital's EMR requires performance measures across implementation, success, clinical effectiveness, technical functionality, project execution, cost management, and scope adherence. Below are the key KPIs and their intended purposes. Implementation success metrics include adoption rate, which is the percentage of eligible patients completing pH screenings via My Avatar, and the target is greater than or equal to 85% based on prior feasibility studies. This measures staff and patient compliance with the new workflow. Second, technical success rate. Proportion of PHQ forms correctly completed without errors. Our target is greater than or equal to 95%. This identifies system reliability issues. Third, staff training completion, which is the percentage of clinicians and front desk staff completing My Avatar training modules. This ensures competency with the PH9 integration. Clinical effective metrics include the PHQ utilization report, which is the frequency of PHQ9 use for new depression diagnoses. Our target is greater than or equal to 70%, and ongoing monitoring, which our target is greater than or equal to 60%. This tracks integration into clinical workflows. The depression indication rate will be the percentage of patients newly diagnosed with moderate to severe depression, which is a PHQ score greater than or equal to 10, compared to pre-implementation baselines. Also, the treatment adjustment rate is the proportion of cases where PHQ-9 results directly inform medication therapy changes. This measures clinical utility. We'll also measure functionality and technical performance. We will measure the form completion time, which is the average time for patients to complete the electronic PHQ-9. Our benchmark is less than or equal to 5 minutes. Data accuracy will be measured, which is the rate of PHQ-9 fields left blank or requiring clinician amendment post-completion. Our target is less than or equal to 5%. We will measure EMR integration quality, which is the frequency of system downtimes or sync failures impacting PHQ-9 access during visits. We will also measure project execution metrics, including schedule adherence, which is the on-time completion of implementation phases, software configuration, staff training, etc., using Schedule Performance Index, SPI. We will also measure budget variance, which is the difference between planned versus actual cost for EMR customization, hardware, training, and our target is less than or equal to 5% overrun. We will measure scope compliance, which is the percentage of predefined features, automated scoring, trend visualization, and we will measure that this was successfully deployed. We will also measure user experience and satisfaction. We would like the provider reported ease of use to be the target greater than or equal to 80% approval and perceived impact on care quality via post-implementation surveys. Patient acceptability will be measured, and this will be the percentage of patients rating PHQ-9 electronic completion as private, clear, and valuable. We target this to be greater than or equal to 75%. These metrics collectively assess whether the My Avatar integrated PHQ-9 improves detection, streamlines workflows, maintains fiscal responsibility, and aligns with psychiatric care standards. Regular monitoring enables refinement to both the tool and implementation process. During the design phase of the SDLC, advantages and limitations should be considered. Implementing information science and technology project plans enhances clinical decision making. Automated PHQ-9 workflows reduce manual errors and can improve early diagnoses. Structured PHQ-9 data captures standardized information, improving interoperability across systems. Real-time data enables health trends and proactive interventions. Automation reduces staff workload while improving patient access. Limitations include cybersecurity vulnerabilities and patient privacy risks, which arise when sharing data across platforms. User resistance and workflow disruptions can also be a limitation. Clinicians can ignore decision support alerts due to poor integration with workflows or alert fatigue. Clinical experts, technical experts, and educational facilitators are needed to gather data. Clinical experts familiar with depression screenings and treatment protocols, including psychiatrists, psychologists, and nurses, are needed to interpret PHQ-9 results and help integrate into workflow. EHR specialists are needed to integrate the PHQ into My Avatar and ensure seamless documentation. Data analysts must manage data collection, privacy, and analysis. Nurse educators must train staff in administering the PHQ-9 and integrating it into workflows. Administrative support and stakeholder engagement are also needed. In the implementation phase, testing results will be documented in Azure using standardized testing scripts that include date, author identification, and a clear description of the test performed and findings. Screenshots, error logs, and test case outcomes will be attached to each test entry. For failed tests, issues will be documented in a centralized issues log, including details of the failure and responsible parties for resolution. Test scripts and scenarios are required in the testing phase of the PHQ-9 implementation. Predefined scripts simulate real-world scenarios and workflows, documenting outcomes for each. Direct observation is an important element to see users interacting with the system to identify usability issues and workflow bottlenecks. Core elements to test are functionality, usability, interoperability, security, performance, and integrated workflows. The testing mitigation plan includes risk identification and contingency procedures for common issues. Before testing, potential risks must be identified, such as incomplete data capture, workflow mismatches, or system integration failures. Step-by-step backup plans for common issues like system downtime, data access problems, or failed integrations will be developed. Pilot testing will be used to catch and address issues early. After each phase, findings will be reviewed, documentation will be updated, and implementation will be adjusted as needed. Training and support will be available during and after testing to quickly resolve user-reported problems. After go-live, the implementation will be monitored continuously for new issues, and user feedback will be collected. Mitigation strategies will be updated as needed to maintain solution quality and reliability. As we transition to the testing phase of the SDLC, we must validate the implementation of a PHQ form into My Avatar. The following evidence-based methodology will be used. Technical validation will include integration testing. Will verify seamless integration of the PHQ-9 form into My Avatar workflow. We will test whether scores auto-populate in a flowsheet and trigger alerts for high-risk patients, which are scores greater than or equal to 10. With technical validation, we'll also measure data accuracy. We will confirm that the PHQ-9 responses are accurately recorded and stored in a flowsheet. Security compliance will be tested. We will ensure HIPAA-compliant administration and storage workflow and usability assessment. Staff adherence will track compliance rates through My Avatar audits. Time efficiency. We'll measure time spent administering and documenting PHQ-9s. We will optimize workflows by providing feedback. We will survey clinicians on ease of use and integration into existing processes. Resistance from overburdened staff is a common barrier requiring training. Clinical validation will be done with correlation with diagnoses. We'll compare PHQ-9 scores with clinical diagnoses to validate sensitivity. Outcome monitoring, we'll track treatment adjustments, including medication changes, therapy referrals, etc., which are triggered by PHQ-9 results. Compliance and reporting, we will test documentation standards and ensure all scores are recorded in standardized MyAvatar fields. Regulatory alignment, we will audit for adherence to CMS guidelines and value-based care requirements, which incentive PHQ-9 use for depression screening. Finally, stakeholder engagement. We will assess accessibility via surveys for patient feedback. Nursing and provider training will be implemented in multimodal education, huddles, emails to boost adoption. To evaluate the success of implementation, 2 tools and methodologies stand out for their alignment with healthcare management and outcome measurement. SmartSuite has customizable templates for tracking PHQ-9 administration workflows and compliance protocols. SmartSuite also has automated reminders for follow-up screenings and task assignments. It also has dashboards to monitor adherence metrics, for example, the percentage of patients screened at admission or discharge. SmartSuite's healthcare-specific features support the operational aspect of PHQ-9 implementation, such as standardized workflows and ensuring staff compliance. Its automated reporting reduces administrative burden while providing real-time visibility into protocol adherence. Also, there is a tool called Earned Value Management, or EVM. This tracks cost and schedule performance indices to quantify budget adherence and timeline efficiency. It integrates with project health checks to identify delays in PH integration or staff training. EVM provides objective metrics to assess whether the project stays on budget and timelines, such as delays in EMR customization or clinician onboarding. The testing mitigation plan includes risk identification and contingency procedures for common issues. Before testing, potential risks must be identified, such as incomplete data capture, workflow mismatches, or system integration failures. Step-by-step backup plans for common issues like system downtime, data access problems, or failed integrations will be developed. Pilot testing will be used to catch and address issues early. After each phase, findings will be reviewed. Documentation will be updated and implementation will be adjusted as needed. Training and support will be available during and after testing to quickly resolve user-reported problems. After go-live, the implementation will be monitored continuously for new issues and user feedback will be collected. Mitigation strategies will be updated as needed to maintain solution quality and reliability. This methodology balances technical, clinical, and operational factors, leveraging lessons from behavioral settings. Stakeholder feedback is critical to overcoming resistance, ensuring sustained adoption. Maintenance closes out the system development lifecycle. Maintaining the MyAvatar PHQ-9 workflow involves various ongoing tasks to ensure its optimal performance, security, and reliability. The PHQ-9 workflow will be periodically optimized for performing by analyzing and improving the depression screening workflow. The My Avatar software will be kept up to date with the latest patches and updates to benefit from improvements in functionality, security, and performance. We will monitor PHQ-9 trends and plan for updates or performance requirements. We will establish mechanisms for collecting feedback from users and administrators to identify areas for improvement and address any user concerns promptly. The development of the My Avatar PHQ-9 will significantly enhance the ability of healthcare facilities to monitor, analyze, and address depression screenings. By enabling the electronic PHQ-9, the project will lead to improved patient safety, improved decision-making, and targeted interventions for patients with depression. Despite potential challenges, the project's feasibility lies in its potential to streamline data management, facilitate evidence-based practice, and ultimately enhance patient outcomes within the healthcare setting. The electronic PHQ-9 meets the regulatory compliance standards of safety and reporting. Time and money will be significantly saved with the reduction of manual time-consuming tasks and reduced paperwork. Also, enabling proactive measures and interventions will improve patient outcomes and will ultimately reduce costs associated with complications. This is my reference page. These references support the information presented. Thank you for listening to my presentation for the PHQ-9 implementation in My Avatar. I appreciate your time and welcome any questions you may have.